All right, good morning, everybody. Welcome to Department of Surgery Grand Rounds, although we do have a general surgery theme today. This morning, we are having our annual Global and Rural Surgery Grand Rounds. I'm not going to do too much of an introduction other than to say we're super excited to continue to have the opportunity for this progress in our department. Dr. Barclay Stewart has been the program director of this program. And we're going to hear some exciting things about it today, as well as a new opportunity for our residents, where Dr. Lynch is the site director. So I'm going to hand off to both of them and let them talk about some great things coming.
Yeah, I'm Barclay Stewart, one of the surgeons at Harborview and one of the co-directors of the Global and Rural Surgery Program with Dr. Smain, Greenberg, and Dr. Lynch. I'm going to keep it really brief just to save some time for Dr. Lynch and Dr. Riha, who you'll meet shortly to talk. But I wanted to highlight a few things from our last year and how we've been working to build the program. From our research side, we've maintained our Fogarty Fellowship, which a lot of our prior residents have been able to use as their key funding for the research years. We've also added a new Fulbright Fellow in Nepal, doing work predominantly on fire prevention in slums, an ITHS scholar, and then a medical organization for Latino advancement scholar who's going to start in August that we're really excited about. We've supported lots of projects related to PhD dissertations and master's thesis and projects for residents in general, and have maintained both internal and external funding to keep this work afloat. All of us involved have done lots of work outside of the US with different outreach and collaborations. And we've been really proud to see resident leadership start to emerge with Dr. Mehta, who's now the chair of the ACS RAS Global Surgery Working Group. And she won this year the International Society of Burn Injuries Kawhi Young Investigator Award, which is an international, very competitive research award. And Dr. Wild has become one of the core members of the International Blast Injury Research Network, and has been tapped to lead some really inspiring work from the UN Mine Action Service on preventing death after blast injury that you'll hear about in the upcoming surgical newsletter. But we're here today to launch and disseminate our information about the Billings UW Rural Surgery Tract. Many of you have had the privilege of knowing and working with or training under Dr. Lynch. And for those who don't, this is the only photo of him that I could find online, which looks suspiciously similar to a mugshot. I'm not sure how correlated those two are. He introduces himself as a simple surgeon, but Dr. Lynch is certainly far from that. Very soon after becoming a physician in Canada, he set out to the Arctic to work at Ungava Hospital, just up by the Labrador Sea. And mere moments after he arrived, the medical director decided to leave. And not a short leave, but permanently. And Dr. Lynch had a field promotion to be the hospital's director general. Doing so, he developed a passion for rural health and has maintained a focus on training general surgeons, creating a pipeline for surgeons to work in rural communities, highlighting rural surgical disparities across the US, and creating solutions to address some of the key issues that surround rural surgical care delivery in North America. And because of this work, he's regarded as a national expert in rural surgical workforce. And for those of you who have trained under him, certainly an absolute steadfast advocate for our residents' education. And it is only by way of his motivation to develop a rural surgery program has the Billings UW Rural Surgery Tract come into fruition. And I'll turn it over to Dr. Lynch to set the stage a little bit more broadly about rural surgery in America, and then introduce Dr. Gordon Riha, our guest speaker, and now key collaborator in the Billings UW Rural Surgery Tract.
Thanks, Dr. Stewart, for the introduction. Before introducing Dr. Riha, I'd like to add a little background to this new Department of Surgery program. 17% of Americans live in rural areas in the Washington, Wyoming, Alaska, Montana, and Idaho or WWAMI region. Fully 35% of people reside in rural areas. Our medical school and consequently our department serve the largest rural landmass and the largest rural populace of any medical school or surgery department in the country. General surgeons are the second most prevalent physicians after family practitioners in these areas, and they are a crucial component of rural healthcare. Besides providing basic access to immediate surgical care in their communities, the fiscal viability of small hospitals often depends on their presence. Trauma care is also a crucial component of their practice, and the presence of an ATLS certified general surgeon in rural areas is correlated with increased survival from trauma. They provide critical backup for family practitioners in these rural areas who are often loath to locate in communities where they don't have general surgeons present. They are frequently called upon to do procedures outside the conventional realm of general surgery, including C-sections, fractures, ENT procedures, and urology, depending on what other specialists are present in the community. And they are often the de facto critical care expert and nutrition expert in these small hospitals. However, the number of general surgeons in these rural areas has continued, already less than their urban counterparts, has continued to decline in proportion to the population over the past 30 years. And they tend to be older and closer to retirement. The reasons are varied. One is economic, small hospital closures and poor reimbursement due to lack of an insured populace. And then also recruitment lack of recruitment of students from rural areas into medical schools and giving them rotations in medical school in rural areas. Another reason is relevant to this Grand Rounds is training. Many or most surgical residencies don't provide rural experience, and even as importantly, don't provide opportunity for training in the subspecialties such as OB-GYN, ortho, ENT, or urology necessary for practice in these areas. The UW School of Medicine is a longtime national leader in rural healthcare and training and research. The WWAMI Rural Health Research Center is one of the oldest in the country. There are rural underserved opportunity programs for medical students at the UW to rotate in rural areas. And each of the WWAMI states provides a site for the first 2 years of medical school for students from its states to get educated there. There are rural rotations in surgery for third-year medical students, thanks to the efforts of Dr. Roger Tatum and Dr. Jay Erickson. And there are UW residencies in family practice, internal medicine, and psychiatry, where some or all of the training is done in rural areas. However, the search for a site for a rural rotation in general surgery has taken more than a decade and a half. The suitable site requires a complex combination of components. One is you need a large enough hospital with a cadre of general surgeons and subspecialty surgeons who are willing and able to train residents in these areas. You need a supportive administration. You need funding from the host site, and you need remote rural experience in outlying small hospitals. Billings is such a place. Most of all, you need somebody like Gordon Riha, the future site director of the Billings UW Rural Surgery Program. Dr. Riha is a native Texan. He went to medical school at Baylor. He did his surgical residency and surgical critical care fellowship at OHSU. He then went to Billings, where he is assistant trauma medical director at the Billings Clinic and clinical assistant professor of surgery at the University of Arizona. He's a member of the Montana State Trauma Care Committee, and he has multiple publications and presentations on the subject of trauma and rural surgery. His research interests include rural trauma development and education, equine-related injuries, and ursine-related injuries. Before turning it over to Dr. Riha, I would like to thank a number of people who have been instrumental in developing this program. Jay Erickson, the Montana State WWAMI dean, who has relentlessly searched for a suitable site for this project over the past decade and a half. Dr. Doug Wood, our chairman, whose leadership, vision, and support have made this possible. Dr. Rebecca Peterson, who has agreed to take on yet another task at the beginning of her a residency program directorship. And then the program support, admin, and legal arms here at the UW, Joanna Ames, Kira Martin, Cindy Hammer, and Hunter Duman, and their counterpart at the Billings Clinic. Finally, I'd like to thank Dr. Barclay Stewart, my partner in this project, without whose organizational ability and relentless enthusiasm, it would not have happened. Take it away, Gordon.
Thank you, Dr. Lynch. I appreciate it. I'm going to pull up my presentation here real quick. Okay, does everybody see that right there?
Yeah.
Perfect. Sounds good. So thank you for having me today. We've got a lot of material to get through. I'm well caffeinated here in Montana. Let's get started. So I have no financial disclosures, but I have some other disclosures. So I'm not a basic science statistician or anything like that. I don't have any advanced degrees in education. After I graduated from surgical critical care fellowship, I actually have never practiced surgery in a town of greater than 100,000 people. You know, what I do is basically rural-based care, whether that be at the Billings Clinic or critical access hospitals throughout Montana. So that means that if somebody gets kicked by a horse and has a massive liver laceration, if they have a severe necrotizing soft tissue infection, or they unfortunately have a stab wound to the box, and I'm tasked with taking care of them and have to change shoes at the end of the day, this is kind of my daily workflow, if you could say. So here's what this talk is not, right? So I'm not going to talk about basic science. This is not, as much as I'd like to talk about advanced surgical techniques, this is not what I'm going to talk about. And this is not a diatribe on guns or gun violence. The reason I say that is I actually spent the first few years of my life in Douglas, Wyoming. Douglas, Wyoming is a very small town that's about 45 miles southeast of Casper. And this is actually my first hunting trip. This is my mom. I'm not sure if I was excited about this antelope that she shot or not, but this is the way that things started. And so I moved to Texas in my kind of early teenage years. And this was my first, you could say, big buck that I shot. This kind of, I kind of got the bug with hunting with this. And I still hunt today on my parents' ranch. And I make sure that I always practice gun safety when I'm in the deer blind with my 300 Ultra Mag and Princess Elsa and my daughter. So we always make sure that we're safe. So hunting is something that I want to pass on to my children, and it's something that we're involved in on a yearly basis. So when I was in Texas, I attended Texas A&M University and then went on to Baylor College of Medicine in the early 2000s. And for those who don't know, this is Ken Maddox. Ken Maddox is a god in the world of trauma. And for the medical students and residents who have never met Ken Maddox, he is at times a very scary man. So when I was listening to Grand Rounds with Ken Maddox in the early 2000s, I was a medical student. I was kind of falling asleep, right? And all of a sudden he said, if you give extra fluid, you will pop the clot and they will die. And I woke up and I was like, wow, this is amazing stuff. And ultimately, hypotensive resuscitation is something that we use even now today in the world of surgery in Montana. So I went on to surgical critical care fellowship, residency surgical critical care fellowship in Portland, Oregon. I have to credit Dr. Martin Schreiber, who you all know very well there in the Northwest. I'm just a phenomenal surgeon, an incredible mentor, and I appreciate everything that he has done for me in getting me to the point where I am today. So, I live in Montana. I love living in Montana. In the summertime, I'm, fly fishing for huge brown trout in the Bighorn River with my family. In the wintertime, I'm snowboarding in Red Lodge and Big Sky. And ultimately, Montana is a fantastic place to raise a family. And I foresee myself basically living here for the rest of my life if possible. So what are we going to do today? So we're going to talk about disparities in the general surgery training and its impact on the rural workforce. We're going to talk about this rural surgery track that has been created with a collaborative effort between UW and the Billings Clinic. And then we're going to talk about some unique rural surgical care situations in which we expect UW residents to be exposed to during their time here at the Billings Clinic. So let's talk about rural. Let's define rural, right? So Montana is a massive state. If you drive from the southeastern tip to the northwestern tip of Montana, it's actually the equivalent of driving from Washington, D.C. to Chicago. And despite this huge landmass, there's only 7.4 people per square mile. There is more antelope in Montana than there are people. This kind of gives you an idea of how rural we truly are. And this is a challenge, providing care in this sort of state, right? So we actually, our hospital service area is larger than the state of New Mexico. And we provide care in Montana, Wyoming, and the Western Dakotas. So further challenging this realm of kind of providing care in a rural situation is actually the workforce itself, right? So there have been multiple publications out there, as Dr. Lynch alluded to and Dr. Stewart alluded to, identifying that there is a massive general surgeon shortage in the United States. And this has a particular impact on rural locations. So general surgeons, and one of the reasons I wanted to be a general surgeon is because general surgeons are like Swiss Army knives, right? We can do pretty much anything. We can take care of surgery patients, we can kind of delve into ENT, urology, right? During COVID in the ICU, I took care of COVID patients. When I'm out in the critical access hospitals, I'll take care of asthma and other things, right? We pretty much can take care of anything. I've told people, and I talk to my partners, like, if they teach me how to do cardiac cath, just give me a couple tries. We can probably do that as well. We're happy to do pretty much anything out there. And this is important in Montana because if you look at the latest AAMC estimates, 50% of the general surgeons in Montana are over the age of 60. I have one partner who is 73 years old, but doesn't want to retire because he doesn't want to ultimately put the onus on care to others. So I'm going to put it out there that ultimately what this is a training issue. And there is some great data and great papers out there on why people who are in training at the current time, general surgery residents, are not going to rural centers. It's because they didn't attend, a rural college. They didn't grow up in that sort of area. Their spouse grew up in New York or LA or something like that. People who go to rural areas usually have an interest in hunting and fishing and the outdoors. But the most statistically significant reason and factor that's correlated with general surgery residents choosing to practice in a rural area is they have completed some sort of training, clerkship, elective in a rural location. So here in Montana, the family practice physicians actually do this really well. So they family practice residents up here. They go to critical access hospitals. They have these rural experiences, these rural electives, and we've been successful recruiting family practice all across the state of Montana because doctors are more likely to practice in locations that they train. Unfortunately, this doesn't happen very often in general surgery, right? And this is kind of the latest data. This is a study from 2018 where they reviewed 268 programs. And in these 268 programs, there were different programs that had kind of required or elective rural rotations, but only four had dedicated rural training tracks. That's why this is so important for us here with UW and Billings Clinic with this collaboration. So I'm going to tell a quick general surgery story, right? So this is Rob Mayer. Rob Mayer just generally kind of contacted me out of the blue about 5 years ago. He was a general surgery resident at the University of Arizona, Phoenix. And he said, I really like the outdoors. My wife and I are thinking, maybe we're thinking about, something rural, but I've never lived in a rural location. And I'd really like to come and rotate with you guys. And we never had residents before ever. And we said, sure, why not? We'll try it. We'll test you out, try you on for size. He came out, he operated his brains out. He had an amazing time in Montana. We sent him out to a critical access hospital. And ultimately, when he finished 2 years later, he got a job at St. Peter's Health in Helena because he wanted to be up here, because he experienced the life of Montana, the lifestyle of Montana, and what it means to be a critical access surgeon. So what we did is we kind of looked at, what was it like kind of working with general surgery residents, right? And we kind of, our partners, we all sat down and we said, it's exciting. It's sphincter tightening, right? Being when you're on the right side of the patient during a lap chole, right? I mean, I haven't had my heart rate at like 130 in like 10 years, but like it was like 130, 140 when you're on like that side of the table, right? And so it's sphincter tightening, but ultimately it was a life-changing experience, right? And we said, you know what? We want to do this more. So we partnered with the University of Arizona, and we just finished an entire year where we had University of Arizona residents, fourth-year University of Arizona residents doing 9 to 10 week rotations with us, right? And they had a phenomenal time, and it was an awesome experience. So let's talk about UW. So here, kind of out of the blue, about 2 years ago, Dr. Lynch, I got a call from a guy named Dr. Lynch. He said, Dr. Riha, I'd like to talk to you about a collaboration. I got your name from Jay Erickson. Can we talk about this? And we talked about this further, and we hadn't even started the University of Arizona stuff yet. And I said, yeah, let's talk about this further. This sounds like a great idea. UW and Billings Clinic have a long history of amazing collaboration with WWAMI and our medical students and training. Let's try to do something with residents as well, right? So we ended up, they introduced me to Dr. Stewart, Dr. Wood. We all liked each other. We developed a prospectus, an MOI, all these different acronym soups that I had never been experienced, had known about before. We developed our team. We had details. We involved a lot of lawyers. Most of the time I don't like lawyers, but the lawyers were great. We developed everything. It was awesome. We finally have the LOI, letter of intent, which is finalized. Dr. Lynch, Dr. Stewart are coming out to spend some time with me on a site visit here in a few weeks. And I have Dr. Hannah Wild, who's going to be starting with me in July. And we are just super excited to have Hannah with us. We just can't wait. It's going to be awesome. So this aligns perfectly with your global health perspective, right? And what we have set up currently is a year-long track whereby residents will have a kind of a rural experience as well as research opportunities here at the Billings Clinic. But we're not shutting the door on other possibilities, right? There is the possibility of UW residents coming out and having elective rotations. This program is in development, but we want to collaborate with you all as much as possible, and we're happy to do basically anything that we need to do to ensure the education of UW residents. So our goal when residents are here at the Billings Clinic is, number one, we want to expose residents to very unique training experiences, right? At Harborview, you guys get amazing trauma, right? You guys get the most complex of the complex in organ transplantation and stuff like that. You don't need to do that here at the Billings Clinic, right? We want to expose you to, gynonc, OB, ENT, urology. If you're out in a critical access hospital and you have to put in stents, if you have to do a tonsillectomy, if you have to help out with a cesarean section, if you have to do an X-fix, if you have to do a burr hole because you're weathered in, and there's no neurosurgeon available, we want you to have those experiences, and we want you to know how to do those things, because that may be your sort of practice in a critical access hospital, or if you are somewhere in the Middle East or in far Southeast Asia, right? And ultimately, we want spending time at our critical access hospitals to experience these things as well, right? We want to ensure confidence in practicing in a rural environment, and we want you to practice with limited resources. I was actually in Livingston the other day doing a small bowel resection, and when you're practicing in that location, I don't have a resident. I don't have a PA. I have no one helping me in scrubbed in except the scrub tech itself, right? And I did a small bowel resection. I go, okay, can you open a GIA? And they go, we don't have any staplers. Okay, that's fine. So I did a hand sewn anastomosis, but obviously I'm doing a hand sewn anastomosis, basically following myself when I'm doing that bowel anastomosis because I have no one else who's helping me, right? I want residents to know how to think outside the box. That's the important part of this rotation, right? And ultimately, you know, it may be a little selfish, but we want to inspire residents to practice in these sorts of locations. So this is just an example of kind of what the resident rotational schedule is like when they spend time with us, right? So they're coming in, they're spending some time on general surgery, they go to Glendive, they go to Columbus, they're spending time in Lewistown. But as you can see, they're spending time on these subspecialty rotations, you know, like urology and ortho-neurosurgery and gynecology and stuff like that as well. So they'll spend time in Lewistown. Lewistown is the quintessential kind of Montana town of 5,000 people with a critical access hospital, 25 beds. This is on the Continental Divide, absolutely beautiful. Remember Lewistown, we're going to be talking about that here in just a little while. Glendive is a location you may be spending time as well. Again, a critical access 25-bed hospital, amazing support from a sole general surgeon in this location. Columbus, amazing location, town of 2,000 people. We go out there and we do scopes in this associated location. Red Lodge, a town of 1,900 people, right next to the local ski hill where we go out and we'll do hernias and other kind of, you know, small day procedures and stuff like that. Here's the resident experience so far with the University of Arizona during the course of the past year, right? So resident one, this is major cases that they were able to log, right? So in 9 to 10 weeks, resident 1, 102 cases, resident 2, 98 cases, resident 3, resident 4, and resident 5 was very enterprising, and he was like very competitive. Not that surgery residents are competitive, right? Everybody's competitive as a general surgery resident. He said, I'm going to beat everybody. So he did 126 major cases in 9 weeks, right? We were talking the other day, all my partners, and we said, you know, it would not surprise me if Dr. Wild next year does 500 cases here at the Billings Clinic. So I'm going to talk about why would she do that number of cases? Because we're busy, right? We are very busy here. It's a tertiary referral center. And we're busy as a general surgery group. So this is just kind of a typical, I just brought this up, just kind of a typical Friday at the Billings Clinic. 18-year-old male, unknown circumstances, secondary to Tinder. I just learned about this Tinder thing. I didn't know about that. And then, so came in, airway was intact. His breath sounds bilaterally. He was hypotensive, tachycardic, had lower extremity paralysis. We immediately hung whole blood, did my secondary survey, had kind of a whiteout of the left chest, brought the patient immediately to the operating room, intubated bilateral chest tubes, XLAP, damage control surgery, pericardial window, had about 3 liters of blood loss, got 4 whole blood, kind of a 1-to-1-to-1 sort of resuscitation, went from there to the CT scanner, saw the reason that he was paralyzed, found other bullets, took him back the following day for damage control, kind of relook, removed all the packs, did an omental pedicle flap into the liver laceration, and ultimately that patient was discharged, did great. So that happens here at the Billings Clinic, right? But what if this happens in Terry, Montana? This is the emergency department and the emergency room, everything in Terry, Montana, because they literally have one room. What if this happens in Ekalaka, Montana, right? This is no joke. This is the backside of the emergency department in Ekalaka. What happens if you're in Ekalaka and this happens, right? So you do what you need to do, right? There's no cookbook, and we're going to talk about how to proceed forward with this. You know, it's damage control, hemorrhage control, it's volume, and ultimately it's getting these patients to definitive care as quickly as possible. And again, there is no cookbook for this. This is not really written. So this is what we like to teach residents about when they're here in Montana. This is a combination of utilizing ATLS, kind of stop the bleed, as well as our Montana team course, which is basically a rural trauma team development course, right? So what if this happens in Montana? So it's hemorrhage control, right? So it's tourniquets, you know, great data coming out of Houston and with you guys as well, that tourniquets can be up for, you know, 4 to 6 hours without risk of limb loss. Usually that's time enough to get these patients to kind of definitive care for vascular kind of bypass and whatnot. It's the ABCs. You know, I still think that hypotensive resuscitation has a place in surgical care today. It was used in combat support hospitals in Afghanistan and Iraq. And in many ways, Montana is very similar to this. And ultimately, it's thinking outside the box. So really the main decision, right, is decision for OR versus transport dependent upon kind of a number of factors, right? And we break those factors into patient factors, facility factors, and then regional factors as well. So with patient factors, right, the stability of the patient and then the location of injury. So in many circumstances, if a patient is far away, right, this patient, the patient may need their spleen removed in a situation where sometimes, this may be watched in a more tertiary care center, or it's that patient, would go for splenic embolization. That is not possible, right, in any sort of critical access hospital. So in those situations, a splenectomy may be warranted, right? OR crew availability and timing. When I'm in these critical access hospitals, it's not just calling the OR crew and having them there at the bedside in 15, 20, or 30 minutes. Bob has to drive down a 5-mile road and shoo away the cows and go over gravel and then drive another 25 minutes on the highway before he even gets to the hospital and is able to open the room and start opening, packs on the back table. This is a little different than practicing in Seattle or Billings, right? Blood product availability, we're going to talk about that here in a little while, and also weather. Montana can be brutal as far as weather is concerned. So let's move forward. We're going to talk about some different examples here. Dr. Lynch, I actually don't, I gave my cell phone to somebody else. Can I just get a time check on you right now? Because I'm a little more than halfway done.
It is 7:03.
7:03. Perfect. I will be done in 20 minutes, and then we will have 10 minutes for discussion and questions. Great. Thank you very much, sir. All right, so let's talk about equine injuries. This is actually one of my areas of focus. We're actually going to be publishing a study here in just a few months in which we probably have the largest series of equine injuries that has ever been published. People come to Montana because they want to try to live the Yellowstone TV lifestyle. So we are seeing a massive number of equine injuries lately. But let's talk about somebody who was a local and lived outside of Roy, Montana. We're going to talk about where Roy, Montana is. 70-year-old male was on a horse with a bunch of his buddies, spooked, his foot got caught in a stirrup. He was dragged for a quarter of a mile. This was at 6 p.m. They were in the middle of kind of BLM land. There was no cell service. They found a cabin. Nobody was home, but they found a four-wheeler and there was keys in it. They said, figure they might as well use it. So they put the patient on the four-wheeler and transported the patient to a highway where they're finally able to have cell service. And a BLS crew arrived 2 hours after that patient was injured. So that patient, they were somewhere kind of out there, right? They went to Roy, Montana, and then from Roy, they went to Lewistown. And to give you an example, Lewistown is basically 120 miles from Billings, Montana. And during this time, one of our fourth-year general surgery residents was on their critical access rotation in Lewistown when this patient came in. So the patient arrived in Lewistown 3 hours after their injury. They were evaluated by the local general surgeon, who is amazing. He's absolutely an amazing individual and the fourth-year general surgery resident. The patient was hypotensive. They did a chest x-ray and pelvis plane film. And as you can see, patient had a very significant symphysis diastasis. So they put on a pelvic binder, took the patient immediately to the operating room, did preperitoneal pelvic packing, and then took the patient to the CT scanner. From there, they saw on the CT scanner the patient had bladder rupture and ongoing pelvic hemorrhage. They take the patient back to the OR, did an X-lap. The general surgeon, who had never done kind of a suprapubic catheter or anything like that before, everything was a mess down there. So he kind of made things up, did a suprapubic catheter, and then packed the pelvis. And then they had an ongoing, quote unquote, massive transfusion. I say, quote unquote, massive transfusion because we're going to talk about that. So they called me. So Scott Smith and the resident called me when all this was ongoing. And I took a picture of my cell phone because right then at the current time, it was -3 degrees in Billings, but it felt like -23. If anybody has ever been in -23, when you walk outside, you can like feel your eyelids like freezing shut because it's so cold. They were unable to transport the patient via ground because basically all the roads were snowed and iced over, and then we were not able to get rotor wing or flight out into them. So they only have 9 units of PAC cells and 9 units of FFP at this critical access hospital, and they exhausted the blood bank over the course of the night. After they exhausted the blood bank, this is going to make other trauma surgeons cringe, right? But they had to do what they had to do, right, in order to keep this patient alive. So they started giving small boluses of fluid. They put the patient on Levofed because that's all they were able to do. And ultimately, they were able to the next morning, the ceiling cleared. They were able to transfer the patient via rotor at 10:43, 17 hours post-injury to us. When the patient got to us, it was a level 1 activation, went directly from the ER to IR. Our interventional radiologist embolized the left hypogastric artery. The patient was transferred from IR to the OR directly. It was a combination case with myself, orthopedic trauma, urology, ortho stabilized the pelvis, urology did a bladder neck repair. We re-XLAPed. The patient had a severe rectal injury with a diverting loop colostomy. The patient, unfortunately, that diverting with that rectal injury, it spewed stool all over the abdominal wall. The patient ended up with abdominal wall necrosis, had to have a reconstruction with our plastic surgeons, but ultimately he was discharged to LTAC in excellent condition just a few days ago on hospital day 64. So this is just an example of what residents can expect when they're at a critical access hospital. You know, I talked to this resident and I said, you know, how was it? She said it was super, super exciting, but I was scared to death. All right, let's talk about bears real quick. So this is something that you may or may not have experienced in Seattle, but it's something that residents, when they come with us, actually get a lot of experience with because we have a huge series of bear-related injuries, something that we're going to be publishing here in the future. So in talking about bears, so this past summer, I was actually fly fishing on the Katmai Reserve in Alaska. And it's different in Alaska than it is in Montana because bears don't care about humans in Alaska. All they want to do is eat salmon, right? And so my buddy, my partner, my surgical partner actually snapped this photo of me fly fishing, landing a rainbow trout. And people are like, oh man, you just like posted like, you know, this bear, like cut and pasted a bear into the background, right? And I'm like, no, it was seriously. So I have to show him this picture where I'm like sitting there at the dinner table, drinking a Coors Light and taking a bear selfie. So this is kind of the way the bears are in Alaska, but it's completely opposite in Montana because when they hear a gunshot, they think that the dinner bell has gone off. So bears in Seattle, yeah, absolutely. I mean, you guys have black bears in Seattle, and it looks like just north of you, you have grizzlies as well. And I'm sure that you get some grizzly attacks that come down from Alaska. So this is a case that the resident was involved in last year, September. This was a elk outfitter looking for an archery wounded elk in a willow patch. He came on a grizzly, a female grizzly and 2 cubs. Unfortunately, there was no tree to climb. The grizzly was onto the guide in a few seconds. It basically bit down on the thigh and the buttock, lifted the guide up and started carrying him up the embankment. You know, the guide was fighting. He was hitting the bear in the face, had no effect whatsoever on this bear. Basically, the bear was chewing on the guide, and as it opened its mouth, as it was chewing, it dropped the guide, and he was able to roll over an embankment, and the bear did not follow him over that embankment. And, you know, I take care of thousands of trauma patients per year, but what this guide said to me, he said, you would not believe the violence that bear displayed towards me. That really got to me, you know, in this sort of situation. So this is kind of, you know, what we see with bear attacks, just, you know, terrible base soft tissue injuries in these circumstances. Another instance that happened last October. This actually, if you look on CNN, this made like BBC and like national news. So you may have heard about this case as well that came to us. the Shoshone National Forest. 2 college wrestling teammates were out shed hunting. A grizzly came crashing through the brush, tackled the first patient. He told me when I was taking care of him, he goes, yeah, it started chomping on me pretty good. So the second patient, instead of running away, then this is what made national news. He went and he ran over and he started punching the bear and to get it off of the first patient, which was his buddy. And so as a result, the bear attacked the second patient, right? And pushed that to the ground and kind of multiple bites on the second patient. The bear left and then came back a time and started attacking that second patient on the head. The first patient, and then ultimately went away. The first patient basically ran. They took turns with their teammates carrying this second patient to the trailhead. The patient came as a level 1 trauma to our center. As you can see, kind of gnarly, significant injury on the head. We had our plastic surgeons take care of this, kind of do a flat-based procedures and repair. And these patients both discharged and are friends for life. And I actually just recently talked to them, and they're doing phenomenal. So there's really not a whole lot out there. And the reason that we like to teach residents about bears, there's really not a whole lot out there in the medical literature, right? There's kind of these brief reports about bears and bear attacks. But really the largest series comes out of like Calgary, Alberta and stuff like that. And there's not many patients in these sorts of series. So in our kind of, in our experience, we like to teach residents about this. And so what we talk about is not just kind of, how to take care of bears, but bear maulings in general, right? So the black bear population is much more significant than grizzly bears, but grizzly bear attacks are like 10 times more common than black bear attacks. And most of the time, these are defensive based attacks, right? So, ultimately the black bear, the grizzly bears, it's usually a sow on most occasions, and they're defending their young, they're defending their food source. Only rarely is this a predatory attack, meaning that the bears are actually seeking out the humans as food. You rarely see this in the news, and we rarely have this, and we see this. So, this is a picture that I took when I was recently in Alaska. It kind of tells you why, they attack heads. So, bears try to incapacitate each other by going after their jaws, right? And so most of the wounds are on the head or on the extremities, because the extremities, they're right, it's defensive wounds from humans. But in kind of reading through bear literature, skull penetration is uncommon. The mouth of the grizzly is not wide enough to engulf the entire human face. I don't know if this is supposed to make me feel good or not, but at least this is out there and you know about it, right? So, when we take care of bear attacks, it's really the ABCs, right? It's control bleeding. We take these patients immediately to the operating room. It's betadine, it's saline, it's massive amounts of irrigation, local anesthesia, tetanus, antibiotics. I was floored when I was in Alaska. The amount of rotten fish that I saw that these bears were eating. So really there's gram positives, gram negatives, kind of all kinds of flora. So we use kind of second, third generation cephalosporins. And really what it's like is taking care of necrotizing soft tissue infections, right? So it's irrigation, it's debridement, it's excision of these wounds, wound vac placement, going back again and again and again, excising what needs to be done, and then working with our plastic surgeons for complex tissue reconstruction, right? And when it comes down to it, there's a lot of PTSD in these patients. We involve psych early and often. This is a picture I took where a bear was actually running to get a salmon, but it looks like it's running towards me, right? But we're talking about the 21st century, right? And, it's 2023 and you have an animal that is trying to eat you. That is extremely disturbing and something that shouldn't happen, but it happens in Montana. So again, we involve our psychiatrists because this is something that is abnormal and not right, but it does happen, and we expect residents to see this when they rotate here with us. So thank you so much for the opportunity to present today. Thank you, to Dr. Lynch, Dr. Stewart, Dr. Wood, Jay Erickson. I am super excited about this collaboration. If any of you ever want to talk to me regarding trauma, regarding rural care, please call me, please email me. Residents, if you are thinking about an elective rotation, if you just want to talk about Montana trauma, or if you're looking for a job, please call me and I'm happy to talk to you at any time. Thank you.
Dr. Riha, thank you so much for being with us today. I'm gonna open it up for anyone who wants to ask a question. Please go ahead and unmute yourself, ask a question directly, and then I'll also be monitoring the chat.
Dr. Riha, I think you've made our entire resident program and myself run to Billings, Montana to train with you. I just want to say thank you to you and Dr. Stewart and Dr. Lynch. We are so excited for this opportunity. My question to you, just thinking about, going forward, how did you go from traditional general surgery training? We know you trained at OHSU and they do have, emphasis on rural surgery, but you basically went from, somewhat traditional general surgery training to doing everything. How did you, on the job, gain those confidence and skills to basically tackle, well beyond what we learn, even with, an elective rotation?
Yeah, that's a great question. And thank you, Dr. Peterson, for for your collaboration as well with this program. Super excited about everything going forward. So your question is regards, how did I learn kind of on the job training? And not only, I'm going to kind of break that into two parts, right? So number one, when I was at OHSU, right, I never said no when I was on different rotations and there was cases that were going, right? So I wanted to make sure that I had exposure to absolutely everything possible. And what that meant is when, for example, when I was, for example, on my colorectal rotation and we were having stents placed during the course, prior to having an LAR, APR, something like that done, before the general surgery team came in, I would come in with I would ask the urology resident if I could be in with them to, spend time to watch, to kind of manipulate a catheter, do stuff, kind of outside the box of what a general surgeon or a general surgery resident is supposed to do, because I knew I wanted to be out someplace like Montana or Wyoming. And so I knew that I needed some of that additional training, right? So it's kind of putting yourself out there, and that's uncomfortable, right? As a resident, because as a general surgery resident, as you get to be a third, fourth, fifth year, right? You get to be somewhat of an expert in your realm, in your box, and you know what you know, and you know how to do what you do very, very well. And to put yourself back in kind of the intern role is uncomfortable. And so, but you need to do that in order to advance your education forward, right? So that's number one. And then number two, when I was a surgical critical care fellow, I went out and I did weekends as a quote unquote general surgeon by myself on the Oregon coast. I don't know if that's allowed anymore or not. I'm probably overstepping my bounds, but I went out because I was general surgery board eligible, and then later board certified. I went out and actually spent time as a sole practice, general surgeon on weekends to give general surgeons a break on the coast, and putting myself out there in the middle of nowhere where I had no one to talk to or ask, how do I deal with this? What do I do? That sort of situation makes you grow up really quickly, but at the same time, it was super exciting, and it ultimately taught me how to function by myself.
But
I want to put it out there to the residents. I know you guys are on too. I would love to hear some questions from you all. as well as anyone else who wants to put something in chat too.
Gordon, do you have any plans to expand surgical services, including faculty and residents at the Billings Clinic, to the Crow Agency or the Northern Cheyenne Reservation?
You must have been hearing some things. So yes, we do. Thank you. That's actually a good point. So one of our general surgeons who is in my group and who works with us, his name is Dr. Nathan Reeb. Dr. Reeb, we call him the traveling man. He's a general surgeon. He does kind of some elective days occasionally here at the Billings Clinic, but his job is basically to go out and provide coverage at different critical access hospitals. And he goes out and he does scopes in Red Lodge, does scopes in Columbus and stuff like that. And the residents actually travel with him to these locations to have those sorts of experiences. And he loves to have the residents with him. He's an outstanding teacher. And we actually are in talks right now with Crow Agency in order to proceed forward with actually going out and doing scopes as well as minor procedures in Crow Agency and on the reservations, which is going to be an amazing experience. And we want residents to experience this because of the significant disparities of care that we have seen here in Montana, and that I think that it's ultimately very, very important for residents to learn in training.
Dr. Davidson.
Excellent. Thanks so much for being here. I really appreciate this. I'm from Montana and recognize the importance of rural care, and had the opportunity to do up and rural rotations. And it was a phenomenal experience. It also can be an isolating experience because you're, the only student, and sometimes in communities, you're, in my case, was the only woman practicing. And I'm curious what you learned from the Arizona students or residents that were rotating. And our medical school has had some really phenomenal experiences in rural rotations and some challenging experiences in rural rotations. And I'm curious just how the group is thinking about how to make sure that we're supporting all of our residents. And in particular, in some communities, there will be residents that are, the only Black resident potentially there, that's the only Black physician. And, we know how much community is important. And how are we thinking about supporting our residents so that this is a good experience for everybody?
Yeah, that's a great question. So the nice thing about being here at the Billings Clinic is we are kind of the mothership in that we have we have 18 affiliate hospitals across Montana, Wyoming, and the Western Dakotas. And what I tell, the general surgeons, as we are, because we talk constantly, right, to general surgeons everywhere. And what I let general surgeons know who are new to Montana or who maybe just be rotating through and here for a very short period of time is ultimately they are never alone. They have general surgeons who are on call 24 hours a day, 7 days a week here at the Billings Clinic, who are here to partner and to help them out in any way possible. So you wouldn't believe the number of calls that I receive from literally from the operating room, right? From Glasgow, Montana, or from people in Plentywood, in the far reaches of northern Montana. And, it may not be for a transfer. It's just, hey, can I run this by you? Can I, help, can we just kind of talk about this? Can we talk this out? Am I thinking about this in the right way, right? Because it's the job of us, of we here at the Billings Clinic to ensure that that isolation does not occur, because this is a network of hospitals whereby there is always somebody available, right? And there's always the resources that are available to individuals, irregardless, of their specialty. So, and as you were, alluding to, as far as diversity and inclusion, we have those sort of resources available and on board, and just a phone call away here at the Billings Clinic as well. So that's kind of your second question. As far as your first question, as far as what the resident experience has been, it's really interesting. We finished the year, and I've sat back and reflected on having the University of Arizona residents here with us. And what I think is really important is, the residents ultimately, they've said that the common theme that has come across is there's a quote, "This is a surgical playground," right? That residents are like operating like crazy. They love it. Every day they're in the operating room. We have the bandwidth to have 5 residents here, right? And there's 1 or resident or 2 residents here. So we have, every day my partners are like, well, I get the resident. No, I get the resident. No, I get the resident, right? So the resident is being pulled in these multiple directions. And so they're basically just operating all day, every day. And as a 4th year resident, that's exactly what you want to do, right? And then, so that's number 1. Number 2, we actually have 2 of the residents who said, I want to come back to Montana or Wyoming. I want this sort of practice. I'm really looking for this sort of practice at some point in the future, right? So 2 of the residents have identified that they actually want to do something like this in the future. And then very interestingly, 1 of the residents at the end of their rotation said, I'm glad I did this rural rotation because I know I never, ever want to do that again. And I want to make sure that I'm in a huge medical center and I have all the resources immediately available to me. I don't want to do this. And it was important, just as much as I think is important for people to know that they want to do this, it's even more important that they know they don't want to do it, right? Because then it's just, we're not promoting something false to them. And then they come out and they spend 6 months or a year and they fail or they don't want to do that. And then they leave these small centers or these small hospitals. So it's just being open and honest and having these residents experience what it's like to be in Montana.
Thanks so much.
We have a couple questions from residents, and it's a little bit more nuts and bolts, but they are super excited by this morning's presentation. Dr. Lavity and Dr. Chan just wanted to know if you could give a small overview of like different types of cases, clinics, kind of schedule stuff, and then maybe talk a little bit more about some of the other research going on where you are.
Yeah, absolutely. So both good questions. So as far as the caseload is concerned, we do basically, I, as a general surgeon, I do everything from hemorrhoids to Whipples. I literally do everything, and the majority of my partners do the same. We do, here at the Billings Clinic, we do everything. We do Whipples, we do esophagectomies, we do liver resections. The only thing we don't do is transplant. So we do all those major cases. We have bread and butter, hernias, gallbladders, all that kind of stuff. I make sure that residents come in with me on a day of clinic and band hemorrhoids and stuff like that. Ultimately, I know probably your some of the program, I'm sorry, Dr. Peterson, but we don't have residents spend much time in clinic. As a 4th year, right? Here, it's mainly operative intervention. If they are in clinic, it's mainly, to do different procedures and stuff like that. And then as far as research is concerned, we have a very burgeoning research program associated with trauma. We have equine based stuff. We have bear based stuff. I presented papers at American College of Surgeons regarding our necrotizing soft tissue infections and our necrotizing soft tissue infection rate, which is actually one of the highest in the world, actually higher than the Philippines. We have kind of the standard, trauma-based stuff, looking at Kcentra and traumatic brain injury. We're doing actually, MBIG criteria, which, originated in Arizona and stuff like that. We're actually looking at MBIG in Montana, which is even more important, right, to look at from a traumatic brain injury standpoint. We're looking at disparities in care. We're looking at rural care. Basically, we have a huge research team. If you come to the Billings Clinic and you dream it up and you want to do it, we can get it done.
Gosh, talk about an exciting presentation and actually perfectly on time. It is exactly 7:30. I want to thank everybody for being here today, and especially Dr. Riha. Again, we're excited about this collaboration, and I'm sure there will be much more to come.
Thank you so much for the opportunity. Have a great day.